So as I continue, okay. So inshallah, tonight we will be discussing about the health data analytics part one. Okay.
Yeah,
So from the very first lecture, we said there is no such thing as memorization ever, right? So it is all
right.
about understanding. So data analytics as well is the last thing because it's easy to understand. So you won't need to review it again, meaning during the review time, you won't need to go back and review it again because as soon as we understand it and apply it to its question, so that's it. So you have mastery of this chapter. And by the way, this chapter is one of the highest scoring chapters for the people who take the exam. So its question come direct and clear. So it's not roundabout or tricky. The questions are meant to test if you understand or not. You will know how to differentiate between the two types of data, when is the data quantitative and when it is qualitative. So you will know also the tools used to display the quantitative data, the graphs used to present the quantitative data, and the graphs used to present the qualitative data also. And you will know how to differentiate between them. Data analytics is divided into four parts. Tonight, inshallah, we will take the part one first. Okay, so let's begin together. I want to ask, why do we need, or why do we even do data analytics? Because data analytics, which information management is based on, helps me to put people in the right order. Okay, so and consequently in the right place, doing the right thing at the right time, and therefore achieving the right outcomes. Consequently, I will get the right outcome that I want to achieve, the good patient experience. So, data analytics help us to take the action needed to be taken. It will help us to know what action do we need to take. So, do I really have a problem and need to work on an improvement project? Or do I not have a problem and I just need to monitor the process I have? So, what does data analytics even mean? Let's talk about it. Okay. When I say information management, it means that I equate the data and information as one thing. What is the difference between these two? Data is the raw is the raw and unorganized facts that need to be processed. Okay, it is facts, but these are unorganized. Okay, these are unorganized facts. Therefore, I cannot rely on them to make a decision because they won't help me at all in the decision making. For example, if I told you I have a patient fall rate of 25 patient falls happen, or if I told you surgical site infections, there were, for instance, 10 cases of surgical site infections. So there are indeed facts that 25 patients experience falls and that 10 cases involve surgical case infections. But does this data help me and determine if I have a problem or not? Does this limit or level represent a risk or not? It did not help me make a decision at all. I didn't know if the 25 patient falls happen over a month, a year, 1 month in one department, or across the entire country. I didn't learn anything at all from the data I mentioned. Now, if I gather the patient fall rate or the surgical site infection data over 6 months and compiled it into a table to see across the first month, second month, third month, and so on, and then organize all the data into a table, and then displayed the table on a specific graph based on the type of data, then displayed it on a graph. Like this, I am transforming this data into information because I process the data. Okay. First, I organize it and arrange it in a table. Then I displayed it on a graph. So in this way, I am transforming the data I have into what? Into information.
Information,
And this information will give me what? Knowledge.
knowledge.
Yes, I will have insights and knowledge. This knowledge is what will help me in the decision, okay, making.
Decision making.
Yes. However, raw facts and unorganized data will not help me make a decision. I don't know if this rate is high or low, over how many months, whether the patient fall rate is increasing or decreasing. Okay, so I don't know. So when I gather the data very well, organize it, then display it on a graph and analyze it, I will have the knowledge. And this knowledge will help me in decision making. So this, in summary, is what we call information management systems. This is essentially what happens in data science. The first thing I do is to determine the project scope. I want to identify the data we are going to collect. And this is considered the most important steps in the data collection. It is the proper identification of data. So the person who will collect the data must be given a specific criteria and accurate identification of the data they are going to collect so that this data can be included easily. After that, the data collection and collection tool is determined. So the one that will be relied upon for data collection, then we proceed to collect and aggregate data. By gathering the data, organize it, and place it in the table. Observe the flow of the funds, and the timeline of any action. Afterward, present the data or display visually on a graph, depending on the type of data that we have collected. Next, place the data on a graph and perform and analyze and interpret. For example, we might say this graph shows that the patient fall rate during the period from such and such month to such and such month increased, while the rest of the year the rate was low or acceptable. What did I do here? I transformed the data I had into information and this information into knowledge. And my knowledge aids me in the decision making process. This is the foundation of the data science. I have data. This data is displayed here that it shows that the risk factors for 2017, 2018, and 2019. Okay. In here, I want to put this data on the graph. And basing on this graph that I have displayed here, I want to interpret this data and determine what I need. So for example, on the graph, I can say that these results show that there's a high rate on most of the days. Okay, most of the days. So meaning here, and this is due to this is due to non-compliance with the care of healthy habits and standard precautions during infection of risk factors. So now I know, basing on this data, that I have a defect in compliance with care. Okay, so therefore, the action that I will take or the decision I will make is to figure out how to increase the compliance in these areas. Thus, I have transformed the data into information and interpret it. This means I have completed the whole process. The purpose of data management, therefore, is to support decision making, and supporting decision making means improving outcomes, improving healthcare, improving patient safety, improving performance, and improving patient care. Okay, in here, in the rate of CAUTI for the year 2017, the data analysis and reporting frequency here is, it is noticed that the rate of CAUTI is high in most of the year. Okay, in most of the year. And this is due to non-compliance of the staff with care of CAUTI bundles. You're familiar with the CAUTI bundles, right? And the standards precaution during insertion of the urinary catheter. Okay, so this is the example from data to information for us to have the knowledge to help us to decide or to have our decision making. Okay.
Okay, Assalamualaikum.
Walaikum salam. Dr. Lam, welcome. Good
Yeah, just
evening.
coming from prayer.
Okay, welcome.
So,
Okay, so the steps of information management, we started with the first phase.
okay.
Okay, here
Yeah,
is the first phase, which is the design phase. This involves identifying the data to be collected, setting a plan for data collection, and selecting the data collection method or data collection tools. After that, we move on to data collection, okay, and gather
yeah,
the data. The data you have gathered will then go through aggregation and organization, and you will use statistical methods analysis okay such as what tables.
yeah.
Okay, we have the graphs to aggregate it, then you transform it. Okay, this transform and display it on the appropriate graph. So you have transformed the data you have into what? Into
Better
information, right?
information.
Data to information. The information that I have created will then go through interpretation and understanding to achieve an understanding of the data, which give me what? The knowledge.
Mm,
And what will this knowledge help with? It will help with the improvement of, yes, of
yes,
decision
making.
making. Yes. Data collection from internal sources such as medical records, okay, or the inpatient records, quality management summaries, patient surveys, interviews, indexes, and registers. Okay, these are the internal, and we have also through external sources. When we say internal sources, this includes, as I've said, the medical records and all of this. And there are also index registers and hospital-based data. I can also collect data from the external sources. So such as accreditation reports, validated clinical pathways, identified benchmarks or the best practices, and the reference databases. When the incident report, okay, is prepared and completed, so it contains points with high details and clinical points are wide ranging. Okay, additionally, there are databases coming from outside and such as marketing databases or any reference databases outside the organization and which are considered as external data
Data.
sources. Okay. What types of data do I have? The data is either qualitative or quantitative. These are the two types we will study. Either the data is qualitative, which means verbal, like descriptive data, not involving any values. It might include mission, vision, values, regulatory requirements, political pressures, okay, um, community needs, expectations, religious and cultural pressures, quality management, utilization management, resources management, quality improvement team interpretations, and conclusions. So these are called the qualitative data or words. Or it's quantitative data, which is a numerical or numbers data, such as financial accounting, managerial cost accounting, aggregate performance measure data, okay, patient member demographic data, treatment data, and the comparative data. Okay, so it is quantitative. So for the both, these are, we have the patient satisfaction and grievance complaint, employee satisfaction and moral, and satisfaction data. So this may be collected through qualitatively in the form of through interviews, focus group, or maybe quantified through questionnaires or survey. Now, what about the context of use? The context means, okay, context of use. The context means that the data can be either qualitative or quantitative depending on the data collection tool you use. So let me give you an example. If we collect data about satisfaction and conduct interviews with patients, what we call a focus group, okay? So to see if they are satisfied or dissatisfied, what type of data will this be? Is it quantitative or qualitative?
Quantitative.
It is qualitative. Why?
Why?
Because the data you are collecting from the interview, whether the patient is satisfied or dissatisfied, does not allow you to determine the percentage of satisfaction or dissatisfaction. So when you use a focus group or conduct interviews, the data type is qualitative, quality. However, if we conduct a questionnaire or a survey for patients and the result of the questionnaire tells you that the satisfaction rate is 80% and the satisfaction is 20%, what type of data is this?
Quantitative.
Yes, here the satisfaction percentage is quantitative data. Why? Because we use a tool, a survey or questionnaire
Numerical.
that provided us with numbers. Okay, so these numbers here make the data quantitative. The collection methods are what determine the types of data that I will collect. If I use a data sheet, the spreadsheet, the service questionnaire indicators, and the Likert scale. So, okay, in the Likert scale, pay attention to this. This is a question. What type of data does it provide me? Is it quantitative or qualitative? Okay. The Likert scale and all of this give me numerical data, which makes it quantitative. As for qualitative data collection methods, they include conducting interview, focus, and
Group.
performing observations. What is the focus group? A focus group is a small group of people collected to participate in interviews with a specific focus. What does that mean? It means I will gather a group of people around about 6 to 10 and conduct interviews with them. A focus group means I will interview them to determine their satisfaction and dissatisfaction, the things they are satisfied with, and the things they find dissatisfactory. Okay? Any questions?
Mm.
Okay, these terms that we encounter, especially in the measurements or tools in any variable, must be sensitive, specific, reliable, and valid. So let's understand these terms together. What about sensitivity? It is the ability of a measurement or tool to identify and select all positive cases. In other words, how well the tool or test you're using detects positive cases. Those that are not detected are called false negatives. For example, if I tell you that a test for COVID-19 has a sensitivity of 90%, what does this mean, the 90%? If we have 100 people, all of whom are positive COVID-19, how many will the test detect as positive?
90 are positive.
Yes,
and 10 are false
90,
negative.
very good. It will identify 90 as positive. What about the remaining 10? What
Yeah.
will it classify them as?
False negative.
Very good. It is false negative because I told you all 100 are positive. So if sensitivity is 90%, it will detect 90 positive cases and the remaining are 10 false negatives. Therefore, the higher the sensitivity, okay, the higher the sensitivity,
The
Meaning,
higher the precise.
it will detect 99 positive cases, leaving only one as false negative. Okay. Is it clear now? Radha, do you have any question? Okay, that is sensitivity. What about specificity? Is the ability of the system to exclude all negative cases with few false positives. It identifies how well the tool excludes the negatives. For example, if specificity is 95%, okay, and I have 100 people, all of whom are negative, the test will correctly classify 95 as negative. What about the remaining 5? They will be classified as false positives. If specificity is 99%, it will exclude how many
1%.
negative cases?
1%.
Will exclude 99 negative cases, leaving only one as false positive. Okay, clear, Dr.
Yeah.
Gulam?
Yeah.
Is it clear,
But-
or should I repeat again?
No,
Okay.
no, not it. Just only thing is one question. If
Mm.
among sensitivity and specificity to choose which is the best in diagnosing any case.
Sorry again, Doc.
In choosing sensitivity and specificity, if they ask which is the best indicator to choose in the diagnosis.
Okay. So which is the best? Okay, actually, Doc, in developing, because I am talking about in general in
Yeah,
how to
I'm sorry.
develop a questionnaire or others. So it must be include all of this somehow the components on how to develop a questionnaire. You have to consider all of these components to make your questionnaire effective. Okay, does it
Okay,
make
so you can
sense,
continue.
Doc?
Yeah, yes, continue,
Okay.
please.
So again, I want to repeat this again, the specificity. So for example, okay, if a specificity is 95% and I have 100 people, all of whom are negative, the test will correctly classify 95 as negative. And what about the remaining 5? They will be classified as all false positive. Now, what about 99%? Radha?
99% is positive. Sorry, negative.
Very good. And only one as false positive. Okay, very good. What about for the usability? Okay, this is the relative ease with which the indicator can be understood or the tool can be used. So this refers also to how a user-friendly tool a tool is, and if a tool is complicated rather, and difficult to use, it lacks this usability, because a usable tool should be simple and user friendly. So tool can be used. Usability. What about reliability? It is the ability of a tool or indicator to provide consistent and reproducible results. So for example, if in the first month you measure a value as 95, in the second month it is 90, and in the third month is 98. Is there any reliability? First month measures 95, the second is 90, and the third month is 98. Is it reliable? Is there any reliability?
Above 90%, I think we can make it as a label.
Okay. The answer, Doc, is there is no reliability because the measurements are inconsistent. Reliability means that every time you use the same tool to collect the same data, it gives you the same result. Yes. For instance, if I measure a value as 50 in the first instance, The next 49.5 the second time. Then 50 again in the third time. And 50.5 the fourth time. This indicates
No,
reliability. Because of what?
0.5 difference.
Because the results are close and
Close.
consistent. Okay, so that's the reason. What about validity? What is validity? Is the ability of a tool to measure and what is supposed to measure. So, meaning what is really desired to be measured, meaning there is
Accuracy.
accuracy. Yes. For example, if you are using a test for COVID-19, but it detects a different virus, this test lacks validity because it makes the measure exactly what it is designed to measure. Okay, I have here an example for reliability and validity. So let's use a target to explain. Just imagine you're throwing darts at the target, okay? If every dart lands in the same spot, but far from the center, which means the target, you have reliability, but no validity. Why? Because you are consistent but not hitting the correct target. Does it make sense? So again, if your darts land all over the place with no pattern and none in the center, is there any reliability and validity? If your darts land all over the place with no pattern and none in the center, is it reliable? Is it valid? What's the answer?
No.
Not
Of
reliable.
course, no. Because if every dart lands in the center of the target, then you both have reliability and validity. Okay, clear?
Yeah.
Okay. What about stratification? The classification of data into homogeneous groups or subsets. For example, the study of the UTI by organisms, by catheterization, by surgical procedure, by nursing unit. So that is all about the different components of developing a questionnaire. Okay. Any question?
Okay.
Okay, all right. So let's talk a bit about medical record. What is the importance of the medical record? Of course, the medical record is everything for the patient. So, are we all liable for the medical records of the patient?
Yes.
Yes, because the medical record, as I've said, is everything in the patient's care process. So if we are dealing with a case related to the patient or want to know what happened, for instance, to the patient, we go back always to his medical record. If we want to identify any risk factors the patient was exposed to or want to screen the patient, we will open his medical record. Therefore, the medical record is very important for documentation of the complete patient's history. It is also essential for communication and sharing information among the medical team for legal protection as well. If there's any legal process, we refer always to the medical record. Research. It is also used when conducting any research. They review the medical record of the patient because it can assist in any medical research. Securing patient medical records through efficient data management and access control. Medical record components are patient demographics, which is the name, age, contact information, and insurance details of the patient. Also, the treatment plans. We will see the current diagnosis, the medications, and the care instructions by the doctor. Also, for another component is the medical history. We can review the past illnesses, the surgeries, or any known allergies, and any familial history of the patient. And we can also view the progress notes, which is the ongoing documentation of patient's condition and care. For the efficient and effective filing of medical information concerning a patient's medical history, it is based on the accessibility, reliability, and integrity of the data. It also includes the data accuracy also, the data protection, and data security. It focuses mainly on protection of the patient's information in medical records. So, how can we maintain these medical records? How can we protect the information and confidentiality in medical records? We must always ensure quick and complete information of the data entry. There must be verification of data before double entry. Regular auditing also of the medical records should be conducted. And there should be a continuous improvement and the implementation of backup and updating processes for the documentation of medical records. Additionally, controlling access is crucial. Not just anyone should be able to enter and use the medical records or have access to them. There must be control over this. Limiting access, we have something called a proper security in any application, especially in medical records. This proper security is implemented around documentation. Okay, that includes the typing and correction. For corrections, it says you should only use a single line to mark. For example, if you mistakenly write paracetamol, for example, but the order is, uh, let's say, diclofenac sodium, then you just make a draw straight line in between, okay, and then you just write the word error and your signature, and then you write your correct order. Are you both practicing this one in your
Yes, yes,
facility?
yes. We are
Okay.
doing.
So it says that you should use a single line to mark a mistake and write the correct information, but you must not erase any record or use correction fluid or similar methods. So if there is any late entry, okay, for the time, the date, and signature of every entry, so you must document it as late
LinkedIn.
entry, yes, provided the date and time and the signature. Okay. What about our applications also regulate the use of the permitted abbreviations and prohibit unapproved abbreviations. Usually it can be found in the nurse's notes and beside of the form, and for the doctor's progress notes. Do you have like that in your facility, Doc Gulam?
Yeah, we have actually our APPs and the PPPs because we use the best case. In the best case, it is not
Mhm.
allowed to use the abbreviations, but there are some
Yes.
specific abbreviations which can be used and which are not used, and we follow that one.
Yeah, very good. Okay.
We can give this abbreviation list to all the units so that they can follow.
Yes, there is a memo
Actually, this is the
also.
APPs. The APP means like we just will not send the emails, but it is a complete DPP and APPs will be the different part of the departments.
Excellent. Okay. So, in addition to that, there is also a mobile station access, like for any verbal orders. These There are policies that specify when verbal orders are permitted, how they are documented, and the rotation and destruction of the records for the verbal orders or telephone orders. So we can insult here telephone orders
We can take
also.
only on emergency, not every time.
Yes, yes, exactly. And all the high alert medications, it's not also allowed to accept or to give telephone orders. Okay, so what about for the retention and distractions?
After
Uh,
10 years,
mhm. For how many years that you
10
have
years, we
to
will take the
to
policy of 10
retain?
years.
Okay, very good. 10 years only. Okay, so after which it will be they must destroy, with policies detailing the proper
If it is
method of
electronic, there is
destruction.
no problem, right?
Hmm?
If it's
Sorry?
electronic, no problem. It is already scanned. Or this is only for the
Yes, for the manual
yeah.
medical records.
Mm.
Okay, so there is also electronic security. Okay, here. Information security, accountability, and confidentiality. When we say electronic patient information security is extremely important to maintain the confidentiality of the patient information. So these two have to ensure this its integrity and the availability, the accountability, and confidentiality of the patient's information. Okay, let's move on. The regulation under HIPAA, which stands for Health Insurance Portability Accountability Act, especially regarding protected health information or the
Information.
PHI. Okay. PHI, protected health information, this includes any form of individually identifiable health information in electronic media, paper, or oral communications. It is subject to strict laws. Any release of patient information without a legal reason or the patient's consent exposes you to legal accountability. Okay.
Mhm.
HIPAA applies to individually identifiable health information, whether it is in electronic media, paper, or any oral communication. It is described as supersedes, meaning it overrides the state laws unless the state law is stricter regarding security and confidentiality of the medical record information. HIPAA established key requirements. So we have here for privacy safeguards, for patients' rights protection, and secure communication practices. It's important to know that the privacy rules for medical records were set by the HIPAA. Okay? There should be control through access control to limit record access to authorized personnel only. There should also be proper storage, such as locked card, system for physical records, and secure handling of digital files. So we have also the staff training, educating the healthcare workers on privacy policies and any procedures, and the audit trails as well. This is meaning monitoring and tracking access to the patient records. Okay, another thing is the backup copies should be created also, and we must download backup versions as well. Okay, sometimes we encountered the downtime, right? Sometimes the downtime of the system in our hospital. So we need to have the backup version. What you do, what is the policy in your facility about the downtime system?
Scanning.
Scanning?
Downtime system. When
Mm-hmm.
there is a downtime, we will give hard copies.
Yes, hard copies, right? Same also. Okay, so some people may have heard the term, or we all know about the electronic health record, the EHR, and others might know about it. So let's quickly compare these two. We have the electronic health record, or the EHR, and the electronic medical record, which is the EMR. The electronic medical record, EMR, is a medical file that is specific to each healthcare organization, separate from others. For example, each patient has a separate medical file in each healthcare organization. But if we connect all the data and information related to a patient in one system, and this system is linked to all healthcare organizations, then it is called an electronic health record. The EHR works as a complete system that collects all the data related to the patient from every healthcare provider. The EMR contains the patient's medical history, notes, treatments, and all the information within one practice or organization, that is, within a single organization. Okay, or within one practice organization. The EMR is specific to a provider or office. What about the EHR? On the other hand, includes all EMR data for a patient from all healthcare providers and organizations. It is shared across different healthcare systems. The EHR is designed for sharing data across multiple providers and healthcare systems. For example, if you as a patient visit hospital X and later hospital Y, will the information in your medical file at hospital X be linked to your medical file at hospital Y? Please answer.
They can provide.
Okay. If you as a patient, you visit hospital X and later you go to hospital Y, will the information in your medical file at hospital X be linked to your medical file at hospital Y? Yes, no, it won't.
We are not. We are giving the medical report to the patient.
This is an electronic medical record.
Electronic, we are not doing.
Yes,
But
because
we have an organization which is linked to the Cumberland. So I think we can have an access from one hospital to other hospital if we need. Just like we have a same organization working and we have a 6 hospital under us. And so our one MRN, medical record number, we can access the data from one hospital to other hospital.
Another.
Because we have working under one corporate.
Okay, yes, under corporations, under corporate. Okay. Yeah. To add to that, the doc also, it is not, it won't allow it because an electronic medical record. Okay, I will continue my explanation. Yeah. Because the medical file in each place is separate and they are not connected, doc. However, if the MOH or Ministry of Health implements an electronic health record system, it will mean that there is one system containing all the medical history and EMR data for all patients across all healthcare organizations. Yes, I think this is in relation to what you have mentioned a while ago. So the system links all healthcare providers to each other. So what is the benefit of the EHR? This EHR reduces costs. So for example, if a patient visits the hospital X and undergoes a set of investigations and then goes to hospital Y, they won't need to repeat the same investigations to view the results. With an EHR, all the data is integrated. So all investigations, history, and patient information will appear on the system for any healthcare provider. So this is the meaning of the electronic health record. Okay, any more additions?
No.
Okay, let's talk about informed consent. What is informed consent? In summary, informed consent is the patient's approval and obtained before performing any invasive or high-risk procedures. It is related to procedures, whether invasive or non-invasive. For any procedure, even a simple one, we must get always the patient's permission, okay, and approval, which is called the informed consent. It becomes part of the medical record also. Components of informed consent, okay, one is all details of the procedure, including the treatment plan and steps involved. So this is the full extent of the proposed treatment that needs to be explained to the patient. By the way, who is responsible to explain the informed consent?
Doctor, the one who is
Of course, doctors. So the doctors are responsible to explain. And another component is the alternative treatments. Okay, meaning other available options are presented to the patient. The risks and side effects, if any, and potential complications or outcomes, whether they occur or not from the invasive procedure. We have also the alternative treatments if the patient decides not to proceed with the procedure. The non-treatment risk or consequences of not undergoing the treatment or the procedure. So the patient understands the possible risk of refusal. The informed consent ensures that the patient fully understands all this information, and then he signs it, and a witness is present to confirm the consent. Okay, to avoid misunderstandings, all agreed upon information must be documented and sent to the client, with a potential exception for emergency cases. So, in cases of miscommunication, meaning when there is misunderstanding, we need to provide explanation for all points. Teach back, letting the patient to repeat and explain what they have understood. Clarification by addressing any misunderstandings and questions. Documenting everything that was said, recording all notes and agreements, and sending all information to the client. And we must ensure that there is no misunderstanding at all, because in the end, you must document all informed consent information. Now, is documentation required in all cases? Yes. So what about emergency cases? What can we do then? So in
taking
any cases, yes, Radha?
we are obtaining consent.
Yes. Is documentation required in all cases? What about emergency cases?
Emergency cases also we do the emergency consent.
Okay, in cases of emergency, the patient may be unconscious. So we want to wait to get
won't wait. Yeah, we don't wait. We will take the consent from medical director.
Okay, so we won't wait to get the consent from the
If there is
family.
unknown, if there is
We
unknown,
will not delay taking
delay
the
the thing.
patient into the operating room to explain the required procedure. In any emergency or critical situation, medical treatment is provided without obtaining formal consent, saving patients' lives.
Okay.
Saving
Patient's time and
patients' life. Okay. So the review must be stopped when there is a conflict of interest between the reviewer and the person being reviewed. All right. What is the conflict of interest in this case? We agreed earlier that the best approach to a conflict of interest is
identify the patient.
Negotiation.
Negotiation.
Now let's talk about the conflict of interest in the case of, for example, a review being conducted or any evaluation involving staff members. If the person conducting the review has a conflict of interest, or we do discover there is hostility between them and the person being reviewed, then the reviewer must be stopped immediately. So how do we handle it? First, identification. This is where we start. We need to actively recognize any potential conflicts, especially during things like case reviews or peer evaluations. This step is all about being vigilant and honest about situations that could compromise objectivity. Next, we have the policy implementation. Organizations need to have strong, clear policies in place, and these policies provide guidance for handling conflicts of interest consistently across the board. Without them, things can get messy. Then there's an alternative expertise. Sometimes a conflict cannot be avoided. And that's okay as long as we bring in an outside perspective, meaning other qualified practitioners when conflict arise. Getting input from other qualified practitioners ensures that decisions are fair and unbiased. And lastly, documentation. This one is critical because in every step taken to resolve conflicts should be recorded. Why? Because it creates a paper trail of accountability and ensures transparency. Okay, and this one is recording all the steps taken to address and resolve conflicts of interest. So, in a nutshell, addressing conflicts of interest is about being proactive, setting clear rules, involving neutral experts when needed, and keeping everything above board through proper documentation. And that's how
Conflict,
we
is it
build
proactive or
trust in
reactive?
healthcare. Sorry, Doc.
Conflict is proactive or reactive? Because it is the retrospectively we are discussing about the conflict, isn't it?
I didn't get your question.
Conflict, is it a proactive or a reactive?
Addressing the conflict of interest is about being proactive. So, meaning before it will happen. So,
Yeah, now when it has happened before, now we are discussing. That means it is a retrospective discussion. That means it is reactive. It should be what I mean, what I sense.
Okay. So, because as I said, addressing these conflicts of interest is we can at least prevent this to happen.
Yeah.
Okay,
Yeah.
before it will happen, Doc. So that is the sense of
Proactive.
being proactive. At least we know where we stand and how to adjust and address any conflicts that may arise in the future. Okay,
Okay.
Doc?
Yeah.
So at least we will, this one, we have to identify. That is why we have this 1, 2, 3, 4. Okay, because these are all proactive approach. So this conflict of interest will not happen. So
Yeah,
that is
yeah,
why.
this is important. Yeah, this statement, the conflict of interest, to avoid conflict of interest, if we take these measures, it is a proactive. But already conflict have occurred, and we are negotiating, then it will
Yes.
be a reactive.
Yes. I got your point. Yes.
Yeah.
Excellent, Doc. Thanks for that.
Yeah.
Yes, it becomes reactive. So that is why there is an RCA.
Yeah.
Yes, right? A root cause analysis to look or to check on the different causes, and it should be like it will not be happen in the future or any recurrences in the future. Okay, so that ends our
Thank you.
Review,
Yeah.
our lecture for tonight about data analytics. Do you have any concerns, questions?
Good.
Okay, so we will now proceed